There's the AA revision tune as well, which is at 5:30 by Medical Theatre A.
Hi. So first is, this is also an opportunity for you to be a mock patient for the second year, so you get exposed to what OSCEs are like, and there will be assessors, so you get to learn from them about like the tips and tricks of what you'll be doing next year when you're assessed. Also, there's end of year party on Friday at the Unicorn Hotel, I think. So look on Facebook for more details there. But if you're interested in being a mock patient, it's today, tomorrow, and Wednesday, 5:30 at the Wadsworth New FD room. Thank you.
Hello? 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 Am I getting through? Okay, let's make a start. So today we're talking about colorectal anatomy. I'm not quite sure what's going on with the right-hand screen. It doesn't seem to be showing all of it, but we'll still get by. So there is no practical class for this particular topic, and the reason for that is that you can't actually see a whole lot of the rectum in specimens anyway, particularly elderly specimens. But there is an online adaptive tutorial we've done for you, which you should get an email about fairly shortly. Okay, so we're talking about colorectal anatomy. So Colorectal anatomy literally means anatomy of the colon and of the rectum. Now, anatomists prefer to talk about the entire large intestine, which essentially, which runs from the cecum down here up through to the transverse colon and down towards the rectum and anal canal. So colon's a term that's used a lot by clinicians, mainly in the context of the parts of the large intestine that have tinea coli. Those are the longitudinal smooth muscle bands. But we're going to talk about the whole large intestine today. Okay, so there's the large intestine as seen in a nice coloured image. So as I said, we've got our large intestine starts at the ileocecal valve. So incidentally, it's called a valve, but it's not a terribly effective valve in that it doesn't really prevent regurgitation of feces. So it is actually possible, if you have very severe retrograde peristalsis, for the contents of the bowel to end up being vomited. So it can go all the way up to the oral cavity if things get really bad. We'll have a look at its structure in a second. Okay, so the parts of the large bowel, we've got the ileocecal junction there. Then we've got the cecum. So that's called the cecum because it's a blind structure. Cecal means blind. Coming off that, we've got the little appendix, of which we'll say a little bit, also called the vermiform appendix, meaning like a worm. Then you've got an ascending colon, transverse colon, descending colon, sigmoid colon. It gets its name because it's sort of S-shaped. And then you've got the rectum and the anal canal. So while we're looking at this picture, just notice also that there are three significant mesenteries associated with the large intestine. A little one here, which we'll look at in a second, called the mesoappendix. One that supports the transverse colon, that's the transverse mesocolon. And another one that's not actually labelled here that supports and enables mobility of the sigmoid colon, and that's the sigmoid mesocolon. Now, I've given you some handouts there which you can fill in, which are basically this illustration here. Now, the reason why I give you line diagrams is that you can actually reproduce these yourselves. This is obviously a very nice, pretty picture, but you've got no hope of reproducing that in an exam. So the reason I give you these simple line diagrams is that you can practice them at home. They provide visual notes that you can learn your anatomy with, and you can reproduce in the exam. So those of you who did that for the ureter question got 10 out of 10. But if you don't practice the illustrations, you will have difficulty being able to do exam questions on this topic. So that's why we're using simple illustrations like this. Okay, so this is a very simple illustration summarizing the main anatomical features of the large bowel. So we've got some important organs that are in relation to our large bowel component. So we've got a liver and we've got a spleen. So as we said, the large bowel extends from the terminal ileum, that's the end part of the small intestine, right down through to the anus. Now, extending the length of most of our large intestine, we have the longitudinal smooth muscle coat of the bowel arranged in these elongated worm-like things that are called the tinea coli, or tinea coli. So some books actually give them names, which is probably not terribly useful for you. But you can see that the tinea coli here start off, or they converge on the origins of the appendix, and they run all the way through till the end of the sigmoid colon. Now, another feature of the large bowel, first feature is that distinguishes a large bowel when you're looking inside someone's abdomen, is the presence of tinea coli. Second feature is the halstration. So in other words, these saccular dilations or segments that you see on the large bowel. And these are largely a consequence of the fact that the large bowel has these tinea coli, because you get outbulging of parts of the bowel wall between the taenia coli. So saculations or haustrations are also a key feature of the large bowel. Now, another feature that you see, particularly on the transverse colon and the sigmoid colon, are these little fat-filled appendages. So these are called the appendices epiploiky. So these are a means for the body to store fat in the serosa of the large bowel, and they form these little sort of tongue-shaped things that hang off the large bowel, particularly in the transverse colon and the sigmoid colon. Now, all the parts of the large bowel, as we said, we've got ileocecal junction here. We've got the little vermiform appendix hanging down, and that's quite important clinically, so we're going to spend a bit of time talking about that. Then we've got the blind bit, cecum. We've got the ascending colon, transverse colon, descending colon, and sigmoid or S-shaped colon. And then around about the level of sacral vertebra 3, SV3, you have the junction between the sigmoid colon and the rectum. So there's our rectum, so that's our next part of our large intestine. And then around about the coccyx, so books differ on where exactly the junction is, you have an anorectal junction. So sometimes surgeons use slightly different terminology from anatomists about where the anorectal junction is, but pretty much it's at the level of the tip of the coccyx, and we'll talk about some of the other internal features later on. Okay, so those are the basic parts of the large intestine, and there are two distinct bends in the large intestine. So one here, which is adjacent to the liver. So logically it's called the right colic or hepatic flexure, adjacent to the liver. The second one, need to see it up here, is adjacent to the spleen. So that's the left colic or splenic flexure. So these are defining bends that are pretty much fixed in position and are good landmarks to where you are in the abdomen. So down in the rectum, there's a few internal features we'll look at in a minute, but in the upper part of the rectum, you have what are called the transverse rectal folds. So these are sort of horizontally placed mucosal folds in the upper part of the rectum. What they do is not entirely clear. They may slow down the movement of the stool down into the rectum, but it's not entirely sure that that's very important. But the other bit of the rectum that's quite important is the rectal ampulla. So this is a dilated part of the rectum, and it's the part that you are pretty much aware of when it gets full of feces. So you know when you get that feeling, I've got to go and do a poo, that is when you have feces in your rectal ampulla. Now, obviously if it's appropriate, you go and do your business. If on the other hand you ignore the call to stool, the call to pass a motion, the feces stays in your rectal ampulla, or it may retrogradely move back into the sigmoid colon. And that's not good, because the whole process that your feces is in your lower bowel, particularly down in the sigmoid and rectum, water is being absorbed. So your stool is getting harder and harder and harder. So whenever you get that urge, you have to pass a motion. When the feces gets into your rectal ampulla, you want to get rid of it as soon as convenient. Otherwise you end up having to pass rather hard fecal masses. Okay, so now as I said, there are some mesenteries associated with the large bowel. During embryonic life, the large bowel is supported entirely by a dorsal mesentery. But when gut rotation occurs, parts of the large bowel get stuck to the posterior abdominal wall. So in particular, the ascending colon here and the descending colon are usually attached to the posterior abdominal wall. About 25% of the population have a short mesentery, but usually they're attached to the posterior abdominal wall. Nevertheless, there are parts of the large bowel which have a mesentery that makes them more mobile. So one of them, of course, is the transverse colon, There we go, transverse mesocolon up there that supports the large bowel, transverse colon. There's a little mesentery for the appendix, which we'll talk about in a sec later on. The other one that's quite important clinically is this one down here. So that's the sigmoid mesocolon. Now in some individuals that's very, very long. And what that means is you've got this long loop of sigmoid colon that can twist around its axis. And that's not good. When it twists around the axis, first of all you obstruct the passage of contents through the bowel. But what's more significant is that you can occlude the venous return and the arterial supply, principally the venous return, from the bowel. So you're going to end up with necrosis of the bowel if your twisting is too severe. So that's called a sigmoid volvulus. It's not super common in our society. It's quite common in relatively tall people, particularly East African groups who have quite a long sigmoid mesocolon. Okay, so we push on. So peritoneum, there's the transverse colon there, and the only peritoneum we need to deal with here is this one attaching the transverse colon to the back, to the posterior abdominal wall. Now you will remember, of course, that the transverse colon gets stuck to the back of the greater omentum. So when you look at specimens in the classes, well not for this particular class, remember we looked at the specimens inside the abdomen. When you lifted up the greater omentum, the transverse colon was stuck to the posterior wall of it. Okay, now the attachments for the mesenteries of the large bowel, just very briefly, that's the line of attachment of the transverse mesocolon across the posterior abdominal wall, down across like that, basically across the line of the pancreas. And then down in the left iliac fossa, this is the line of attachment, probably should use that one, line of attachment of the root of the sigmoid colon. So that's the only two mesenteries that we need to worry too much about. Okay, now we need to talk a bit about the large bowel wall. So there's the large intestine. Now, as we said, of course, most of our colon, you have the longitudinal smooth muscle coat arranged in these bands called the taenia coli. As I said, some people give them names like libera, omentalis, mesocolica. That's not so important for you. There's the mesentery supporting the large bowel, and you can see the vascular supply coming through or between the layers of the mesentery. And here we've got the appendices, epiploiky, that are attached to the large bowel. Now, looking a little bit closer, there's the microscopic anatomy of the large bowel. I'll focus on this one. There's the mucosa of the large intestine. Now, what's significant about the mucosa of the large intestine? The function of the large intestine is to basically absorb water and minerals and sort of maybe a few vitamins, but mainly water and minerals. So it's really designed to form a stool. So you don't want to waste water that the body's put into the digestive process, having it come out in feces. You want to reabsorb that water, you want to form a stool, and you want to get rid of that waste material. So the large bowel is designed for absorption solely of water and minerals and not of nutrients. So it does not have any villi on the mucosal surface. So instead, you see you've got these intestinal glands, quite a lot of them, and the intestinal glands, of course, are richly supplied with mucus-secreting cells. So you want to add mucus to the stool, so that makes the stool relatively soft, even as you're withdrawing the water from it. So you want a soft stool that's got some organic content that you've added and some lubrication so the stool can move down the large intestine without tearing anything. So the mucosa, as we said, no intestinal villi, but plenty of intestinal glands. Like every other part of the bowel, you've got a muscularis mucosa, then you've got a submucosa, and you've got a muscular layer in a circular muscular layer there. So, just to summarise those key features there, we've got the primary function of fluid absorption and mucus secretion. We've got no villi, but we do have a simple columnar epithelium, much like everywhere else in the bowel. And you've got absorptive cells, mainly for the water and the minerals, and the goblet cells. And it does have quite a high turnover rate because the large bowel, particularly the lower parts where the stool's getting quite firm, it's exposed to a lot of wear and tear and also some concentrations of carcinogens and so on, so the fairly high turnover of the epithelium, only as long as 6 days. Okay, now that's sort of general features of the large bowel. We're going to look at two particular regions that have a lot of clinical significance. One of them is the ileocecal and appendix region, which of course is significant for appendicitis, and the other one is the rectum and anal canal. Both of those regions have a lot of clinical significance because there's a lot of disease processes go on there. It's actually fairly rare to get a tumour in the ascending colon or the transverse colon. It's much more common to get a tumour in the rectum and anal canal. Okay, so let's start off looking at the cecum, ileum and appendix. So that's a picture of one of our specimens there. There's the terminal ileum coming in, so this is the cecum here. You can sort of see that's the tinea coli there. It doesn't look anything quite as obvious as it does in the books, but that's the reality of what it looks like. And this anterior tinea is actually converging on the attachment of the appendix to the cecum. That's the mesentery of the appendix, that's the mesoappendix. So this person obviously was pretty overweight. There's a lot of fat filling all the appendices epiploica that you can see here. So that's just a line diagram showing you the same things. There's the ileocecal junction about here, that's the cecum. There's the little appendix off like that. And you can see the blood supply there to the appendix from the ileocolic artery. There are a few peritoneal recesses which can be sites where infection can get hold, so sites where you don't have much peritoneal fluid flow and you can get a nidus of infection. So a couple of them are associated with the ileocecal region. So that's just showing you another illustration there. I think we've already talked about that. Now that's the interior of the cecum there. So when you look at the interior of the cecum, the ileocecal valve consists of two sort of elongated lips on the medial surface of the cecum. So they have their superior and inferior lips, and just below it you've got the appendiceal orifice. So if you look at it in one of our specimens there, the little probe is in the appendicular orifice there, which is not very big, very tiny. And then that's the ileocecal orifice there. So you can see the two lips and the opening there. So that's what the ileocecal orifice looks like from the inside. As I said, not a terribly effective valve to prevent retrograde movement of fecal contents. Okay, now we need to talk a little bit about the appendix. The appendix obviously is a little tubular structure coming off the cecum. Now the key feature of the appendix that's relevant to its clinical significance is that both the appendicular artery and appendicular vein run along the length of the appendix. So if you get any inflammatory process in the appendix, the distal part of the appendix can actually lose its blood supply if, say, the appendicular vein thromboses. So the appendix is actually quite sensitive to inflammatory processes in the wall causing a runaway necrosis of the distal parts of the appendix, that's away from the ileocecal junction, because of a problem with appendicular blood supply. So that's how you end up with appendicitis, which you'll learn more about in phase 2. But there's a few little things of clinical anatomy that are relevant to the appendix. So when you look at someone's abdomen, like over on the left-hand side there is a feature that clinicians talk about. And if you take a line from the umbilicus to the anterior superior iliac spine, ASIS is anterior superior iliac spine, about 2/3 of the way along that line you've got a point known as McBurney's point. So this is a surface marking, so we're going from the umbilicus to the right, ASIS. So this is a surface marking for the point where the cecum is joined by the appendix. So this is meant to be a surface marking for where the appendix comes into and joins the cecum. And it's a fairly constant position there. Having said that, while the point of the junction between the appendix and the cecum is relatively fixed and can be defined quite neatly by McBurney's point, the position of the appendix can be in about 5 or 6 different ways. So the rest of the appendix can hang down, it can go up, it can go behind the cecum, whatever it likes, and that all has clinical consequences, because if you get inflammation in the appendix, the signs that the patient will report depend significantly on where the appendix is sitting. So we have a variety of positions that the appendix can adopt. It can be behind the colon, retrocolic, or behind the cecum, retrocecal. It can actually extend down into the pelvis. It can be in a pelvic position. It can be below the cecum. It can be below the ileum. It can even be above the ileum. So all of these positions have slightly different symptoms and signs. So for example, if you've got a pelvic appendix that goes down into the pelvic cavity and it becomes inflamed, the patient won't necessarily get abdominal tenderness. What they will get is a tenderness to rectal examination, digital rectal examination, because all the inflammatory process has actually gone down into the pelvic cavity. And you may have to differentiate a pelvic appendicitis from, for example, something like, excuse me, from a tubal pregnancy. If on the other hand the appendix is sort of sitting up high, then your patient will present with pain or tenderness rather on the lateral abdominal wall. So the position of the appendix determines how the patient will present. So that's why we're telling you all about positions of the appendix. Okay, now how do you visualize the large bowel? We'll move on. So you can visualize the large bowel. The older way used to be with a barium enema, and that's quite useful for showing some of the anatomy to you, but of course it's not necessarily the modern way. So this shows you the halstrations of the large bowel. So that's the segment of the large bowel. These days, of course, more likely your patient's going to be having a CT scan. So that's just showing you an example of a CT scan taken at the level of the transverse colon. So around about level of lumbar vertebra 2. Now, just bear in mind with medical imaging of this kind, you're viewing the section from below. So structures that are on the right side of the patient's abdomen are going to be on the left side of the screen to your view. So, of course, there we've got the liver there. We've got the ascending colon, there's the transverse colon, there's the descending colon. Now, this is a living person without any bowel preparation. So you were seeing the way that the colon would look if you just took someone off the street and popped them into your CT scanner. So there's all the farts waiting to happen, so all the bowel gas there, and that's all the feces there, that's all the stool forming up. So you can see at the level of the transverse colon it's not really very solid. Okay, now the other part of the bowel that we need to spend a bit of time talking about is the rectum. So the rectum and the anal canal are very important clinically because there's a lot of medical problems that occur down there. You're obviously learning about them in the context of carcinoma, and something like 25% of carcinoma of the bowel actually are within 1 finger's length of the anus, and about 50% are below the top of the rectum. So the bulk of carcinoma of the large bowel actually occurs in the terminal parts of the large bowel. And the reason for that is that's the part of the bowel where you're concentrating carcinogens, you're removing all the water, you've got your bowel contents sitting against the epithelium for a longer period of time, and that's where the potential is for neoplastic change to occur in the epithelium. So apart from carcinoma colon, there's also quite a few other very common, not so significant conditions, but quite uncomfortable that occur in the anorectal canal. So anal fissures, hemorrhoids, fistula in ano. All of these problems occur in the anorectal region, so it's quite an important region surgically. Okay, so when you do examinations of patients, one thing that you'll learn to do, I don't suppose you're going to do it right away, is a digital rectal examination, which is very important, and you'll hear the clinician say, if you don't put your finger in it, you're going to put your foot in it, because a lot of carcinomas, as I said, are within palpation distance of the anal canal. So if you have a patient who has perirectal bleeding, you don't do a digital examination, you are medically negligent if you don't pick up their cancer. So you need to know what are the things you're going to feel when you do a digital rectal examination. And these are essentially the relations of the rectal canal. And that's basically what a lot of what that online tutorial we're going to be doing is all about. So we've got a little table here which just summarises those things. I don't want you to learn tables, it's just mainly a checklist. So when you look at illustrations, you think about what's in relationship to the rectum. Now obviously the relations are going to be quite different for the two genders. So obviously anterior relations in women are going to include all the reproductive organs. In men, of course, it's going to include, of course, the male reproductive organs and the accessory glands at the base of the bladder. Okay, now that's just to show you an illustration of the sigmoid colon coming down, and this area here is our rectum in the back of the pelvis, sitting against the lower parts of the sacrum. Now if you look at that in a midline section like that, this is a midline section through a female pelvis, and what are our relations and what are our features? So obviously we've got the sacrum at the back there, and at the front we've got the pubic symphysis. So an important defining landmark here is the tip of the coccyx. We've got, obviously this is a female, so we've got several internal organs. One important muscle that's related to the anorectal junction is this thing. That's the puborectalis muscle. So that's a muscle that obviously arises from the pubis, that's why it's called pubo something, and it loops around the back of the anorectal junction. Now, I've actually drawn it when it's sort of partially contracted because that is its natural state. As you sit there, you are tonically contracting your puborectalis muscle. It's part of levator ani, by the way, which I think some of you have met already, but maybe not all of you. But it's a muscle that loops around the anorectal junction and it pulls the anorectal junction forward. One of its functions is to impede the movement of feces down through the anorectal canal. So it's one of those things that stops you passing a motion when it's not appropriate to do so. So that's the puborectalis muscle. Of course we're looking at a female pelvis, so we've got the uterus and the vagina. We've got the pouches that we talked about in the peritoneum, so the recto-uterine pouch and the vesico-uterine pouch. And we've got our rectum forming at the level of the sacral vertebra 3, that's about here. So above that we've got the sigmoid colon, below that we've got the rectum, and then round about the level of the tip of the coccyx we've got the anus. So, if you look at the passage of the bowel, there's a distinct bend there. So there's two distinct bends. There's one bend which is really due to the sacrum, so that's the sacral flexure. There's another bend that is due to the sling effect of the puborectalis muscle, pulling the anorectal junction forward, and we call that the perineal flexure. So, with this simple diagram you can work out what is it I'm going to be able to feel when I do a digital rectal examination in a lady. So your digit may be, I don't know, about 8 to 9 centimetres long, so it will probably reach that high up. So of course you should be able to feel structures in front of the rectum, so the posterior fornix of the vagina, the vaginal cervix. You may be able to feel anything that's caught in the rectouterine pouch, so sometimes you get tumour cells depositing the rectouterine pouch. Then towards the back, of course, you can feel the sacrum. There are many structures on the front of the sacrum, so you would have learnt about the piriformis muscle. There are lymph nodes palpable on the front of the sacrum, and there are some blood vessels as well. So you need to think about, what am I going to be able to feel when I do a rectal examination? Okay, so let's push on and talk about the rectum and the anal canal. Oh, incidentally, the perineal flexure is not always a bend. As I said, when you pass a motion, that part of this actually straightens out. So you lose your perineal flexure when you're passing a stool down the anorectal canal. And of course you do that when you've relaxed your puborectalis muscle, as well as the sphincters we'll look at in a sec. Okay, so that's the rectum and anal canal, so a picture of the rectum and anal canal. So, as we said, this is the rectal ampulla. It's not actually labelled here, but that's the rectal ampulla. That's one of our transverse rectal folds, or rectal valves, which is in the upper part of the rectum. So that's the lower part of the rectum here. You notice we've got this bowl of muscle surrounding our rectum. So in your pelvis you've got the levator ani muscles. I know some of you have done, but not everyone. And they form a bowl in the floor of the pelvis. And your rectum has to pass through that bowl. And that's basically what you're seeing here, passing through the levator ani muscle. Now there is muscle from the intestine that continues down into the anal region. So that muscle there is the internal muscle, internal circular muscle, and it continues down and forms something called the internal anal sphincter around the anal canal, or the anorectal junction to be more precise. That's the internal anal sphincter there. So that is smooth muscle. It's continuous with the internal layer of the rectum. So it's circular, smooth muscle. So it's not under voluntary control. What it does is, I'm not sure what's the significance of this, but you know when you pass a motion and the little turds get separated off, they sort of, yeah, they get separated off and you get these little sort of stools forming. That's essentially the function of the internal anal sphincter. So it separates the stools off into the component bits that go into the toilet. Okay, so that's the internal anal sphincter. Now, if there's an internal anal sphincter, there's also an external anal sphincter. Now, the external anal sphincter is a voluntary muscle. So it is striated muscle. It's under your voluntary control. So it has three components. 1, 2, 3 there. We'll talk about those in a sec. So that's a voluntary muscle surrounding the anorectal canal. And obviously it's there to stop the movement of feces. So you have to relax the external anal sphincter and relax the puborectalis muscle for feces to come down the anal canal. So we've got our two sets of sphincters there. Now what else you'll notice is the mucosa has some internal features. So if that's the rectum up here, you see, as you approach this line here, you've got these longitudinal folds appearing. So those longitudinal folds are called anal columns, or sometimes they're called rectal columns because there's a difference of opinion about exactly where you put the anorectal junction. So rectal columns or anal columns is fine. In this diagram they're called anal columns. They are longitudinal elevations of the mucosa, and you'll notice as they go down they actually join the neighbour to form these little valves, anal valves, here and here and here. And if you look at those valves in a line, they form a distinct line which we call the pectinate line. So I'll put that in a diagram in a second. And then below that you've got a region which is called the pecten, or the true anus really, and it has a sort of a bluish coloration. Okay, now one thing you'll notice in the illustration is that there's a lot of veins in this region, very richly supplied with veins. And that can be a problem because when they get dilated, they form hemorrhoids. Anyway, we'll push on to the next illustration. Now, another thing, you may wonder if the circular layer of the rectum becomes the internal anal sphincter, what happens to the longitudinal coat? The longitudinal coat of the rectum, when you approach the anal canal, becomes fibrosed. So it forms this band you can see here, which is called the conjoint longitudinal layer. So it lies between the internal sphincter and the external sphincter. So when you pull on the longitudinal muscle coat of the rectum, you actually get this sort of puckering of the skin around the anus. Okay, so let's put it in a diagram. So you've got an illustration like that. So there's our sigmoid colon at the top. We've got, that's say sacral vertebra 3. There we've got our 3 rectal folds, or rectal valves if you like. So they're in the upper part of the rectum. And then the lower part of the rectum, you've got the dilated area, that's the rectal ampulla. There's our levator ani, that's the pelvic diaphragm basically. And the lowest part of that is the puborectalis muscle. Now, we've got 3 parts to the external anal sphincter. They're called the deep, the superficial, and the subcutaneous. Really they function all together, so I'm not quite sure why they're traditionally separated, but that's the situation. So collectively they're the external anal sphincter. As I said, you've got the mucosa thrown into folds, vertical folds, longitudinal folds. They're called the rectal or anal columns. And when they collect together, when they collect together, you get, connected down here, you've got something called an anal valve. Little space above each is called the anal sinus. The significance of that is you can get little infective foci forming inside the anal sinus. The line of the anal valves collectively has a name. We call it the pectinate line. And it's quite important functionally because it separates intestinal epithelium above from squamous epithelium below. We'll talk about that a little bit more in a second. But the pectinate line, in most people, above that pectinate line you've got intestinal epithelium, so that's the simple columnar epithelium. And then below the pectinate line in most people you've got essentially a squamous epithelium, usually non-keratinizing in the initial part, but then becoming keratinizing as you get further out towards the true skin. So the pectinate line is a significant line. Then you've got a sort of a bluish region, and the reason it's so blue is because there are lots of veins in the submucosa. You're probably not in the habit of looking at anuses, but if you've ever changed a baby's nappy, you see that when a little baby sort of pouts its anus at you, you'll see the sort of blue coloration of the pectin. Okay, so another line of demarcation that you'll hear about is, this is a demarcation called the white line of Hilton, which is very, very hard to see. I can't say that I've ever seen it reliably on any specimen, but it's always mentioned because it's a line of demarcation between non-keratinizing squamous epithelium above that line and keratinizing squamous epithelium below that line. So in other words, true skin is below the white line of Hilton, non-keratinizing skin is above the white line. So this can be important clinically because tumours that are going to arise above the pectinate line are likely to be of intestinal epithelial origin. Those arising below the pectinate line are going to be basically squamous cell carcinomas, and yes, and that's probably the main differentiation from the point of view of tumours. Okay, so now just to talk about the junction histologies, as I said, upper rectum, pretty much the intestinal histology, so you've got intestinal glands and you've got goblet cells and so on. And just proximal to the pectinate line, they start to shorten and disappear. At the pectinate line, you've got the simple columnar epithelium replaced by non-keratinized stratified squamous epithelium. So, of course, the potential for the tumours are going to change. And at the level of the external anal sphincter, that's pretty much the white line of Hilton. The epithelium becomes keratinized, so it really becomes true skin. Okay, now, a couple of other things about the anal canal. So the anal canal, as I said, is very vascular. So here we're looking at a very high power picture of the anal canal. So that's the mucosa there. That's our anal columns up the top there. There's this rich vascular plexus underneath the pecten. There's the internal anal sphincter. This is what's the fibrous band that's formed by the longitudinal coat from higher up in the rectum, and that's the external anal sphincter. So you can see you've got this rich venous plexus around the anal junction, around the anal canal. So if you look at this illustration, we're looking just at the anal canal. We've got our anal columns, we've got our internal anal sphincter there, we've got this yellow band is the fibrous coat from the rectum coming down between the internal and external anal sphincters, what's called the conjoint longitudinal layer. So it anchors to the skin. You can see it's anchoring down to the skin. So whenever the muscles higher up pull, it will produce this sort of puckering of the anus. It may be of assistance in getting stools out. There we've got our external anal sphincter. Now the main point we're trying to make here is the rich vascular venous plexus, I should say, rich venous plexus inside the anal canal. So you have anastomoses there between two important systems of venous drainage. The upper veins drain towards the liver, so that's tributaries of the portal vein. The lower veins drain towards systemic veins, so in other words, tributaries of the inferior vena cava. And where they meet in that little anal sinus we talked about, or actually they've got various plexuses. So there's one that are within the anal sinuses, just above the anal valves. So an internal rectal venous plexus and an external one. So those guys where you've got that anastomosis, if you have a poor bowel habit, like if you don't eat your fruit and veggies and you get a bit dehydrated and you ignore the call to stool, and you get really firm stools, you've got to push them out with a lot of effort. And when you do that, of course, you create venous stasis in the lower pelvis. So these little anastomotic veins down in your anal valves become dilated, and essentially you end up with varicose veins of your anal canal. And they can get quite big. So they get bigger and bigger. So big, in fact, that they will then protrude out through the anal canal. And when they do that, they're carrying the delicate intestinal epithelium out into the external environment, and that's obviously very discomforting. So hemorrhoids, internal hemorrhoids, as you're seeing there, are essentially dilated varicose veins of the anal canal that have been pushed out. They push out the mucosa, so exposing the delicate mucosa of your intestinal epithelium to the dry air. And that, of course, makes for very uncomfortable sort of itching and dull sort of pain in the anal region. So they, of course, need to be removed surgically. Okay, now, in the remaining time, we need to talk a little bit about venous drainage, lymphatic drainage, and arterial supply of the large bowel. And this is important because tumour that's going to spread from the rectum and anus can spread by two main routes. One is a venous drainage and the other is a lymphatic drainage. So let's look at the venous drainage of the large bowel. That's a hemorrhoid, okay. Oh, sorry, I should have said the positions of the hemorrhoids. They usually come out in three positions. So that's the clock face of someone's bottom. So 11, 3 and 7 are the hours on the clock face. Okay, so we'll move on to mesenteric veins. Okay, so this diagram is just a sort of a simple summary diagram of venous drainage of the large bowel. And you may know that the venous drainage of the large bowel is through the portal vein, which is carrying blood to the liver. So the portal vein carries all of the blood from the large bowel and the small bowel, carrying nutrients as well as toxins back to the liver to be dealt with metabolically. So the branches that we're particularly interested in, of course, are those associated with the colon. So sigmoid colon, descending colon, ascending colon, transverse is being cut off. We won't worry about that. So those include the superior rectal vein. So this is the vein coming up from the rectum, obviously, which is a tributary of the inferior mesenteric vein. Okay, so inferior mesenteric vein there, and you've also got the superior mesenteric vein like that. So these veins, as well as the big splenic vein from the spleen, collect together behind the neck of the pancreas to form the portal vein. So you can have tumour that breaks out of the muscularis mucosa of the large bowel, gets into the venous radicals, venous small veins there, particularly as we saw so many of them down in the rectum, and can get into the portal system and end up being transported directly to the liver. So it's very, very common to get metastases from the large bowel tumours in the liver. Okay, so that's the blood going into the liver through the portal vein. Now, abdominal lymphatics we need to say a little bit about. When you look at the large bowel lymphatics, there are obviously lymph nodes within the mesenteries. So the mesenteries that attach the large bowel have lymph nodes, and usually lymph nodes are found associated with the large blood vessels of the bowel. So you have, for example, inferior mesenteric lymph nodes, and they receive lymph from what are called intermediate lymph nodes, and quite a few lymph nodes that are directly alongside the large bowel. So if you have a patient, for example, who's got a tumour in the sigmoid colon or descending colon, you need to check for involvement of the mesenteric lymph nodes. So firstly the paracolic, secondly the intermediate, and further along the inferior mesenteric nodes. So they should be fairly easy to find because they're usually along the major blood vessels to the large bowel. Now those are the lymph nodes that are going to travel in the mesenteries. But if you're dealing with the rectum and anus, if you've got a tumour, for example, that started in the rectum but invaded down to the anus, you need to also think about the pelvic lymph nodes. So there are pelvic lymph nodes which are mainly found, or they are found alongside the major vessels of the pelvis. So that picture there, of course, shows you a summary of the major groups of lymph nodes that you need to be aware of. So there are, whoops, sorry, went too far. So there are several lymph node groups in the pelvis. So we're looking at the pelvis from the front, and they're found alongside the major vessels. So you've got common iliac lymph nodes along the common iliac artery there, external iliac lymph nodes along the external iliac artery, internal iliac lymph nodes along the internal iliac. And just to make things a little bit more difficult, there's a set that have no relation to a blood vessel whatsoever, but they're right in front of the sacrum. So there's the sacral lymph nodes. So usually the drainage pattern is going to be from lower to upper. That's the way it should be. And usually it's fairly commonsensical in the pelvis. Whatever is the nearest lymph node is what usually gets the lymph. So if you've got a tumour in the rectum, your first concern is that you're going to get involvement of the sacrum and the internal iliac nodes in the first instance, and then spread up towards the common iliac and eventually the aortic lymph nodes. So that's the sort of sequence that you expect things to happen. Okay, now just to finish off, we're going to talk a little bit about arterial supply of the bowel. So you may be aware that the large bowel actually consists of parts of what was the embryonic midgut as well as parts of the embryonic hindgut. So actually there are two arteries that supply the large bowel. One is the superior mesenteric artery, the other one is the inferior mesenteric artery. So that's just a diagram of showing you the superior mesenteric artery, but I think what we might do is just put it into the line diagram first. Now, the large bowel blood supply, of course, includes an arterial supply to the appendix. So this has to be ligated, of course, when you're removing someone's appendix. There's our little appendicular artery. Comes from what's called the ileocolic artery there, and you can see that the arterial branch runs along in the mesoappendix towards the vermiform appendix wall. Anyway, so you've got a diagram there. I think that's the last diagram you've got, which is basically a simple representation of the large bowel, and we're going to put in the major blood vessels, and it will appear in one go. There we go. So there's a lot of blood vessels there, but actually it's fairly straightforward if we talk it through. So what we're looking at here, this is the superior mesenteric artery. So there we go. So there's the superior mesenteric artery. So you remember that supplied the jejunum and ileum. So it does have all these branches off to the side, the jejunal branches, ileal branches and so on. But what we're interested in today is the supply of the large bowel. So there's the branch that goes down to supply the ileocecal junction, which we call the ileocolic artery. And you've got branches that supply the cecum and a little branch that supplies the appendix. You've also got a branch from the superior mesenteric that supplies the ascending colon. So we call that the right colic artery. And there's a little branch up here, goes up to the transverse colon. We call that the middle colic artery. Now you'll also notice there's this long artery there that goes all the way around here. And that's going to be met by branches of the inferior mesenteric. This is an anastomotic artery. It would be a problem if you had a transient blockage of one artery, because your bowel would become necrotic in that region and you'd end up with a ruptured bowel and you'd die. So there is built into the intestinal supply an anastomotic artery that runs the entire length of the large bowel. So even if you get a temporary blockage of the superior mesenteric artery, you can still get a backflow of blood from the inferior mesenteric artery. So this obviously allows one to survive if there's a bit of a blockage. Now, of course, there are limits to how effective that can be, but it is of some benefit in some types of obstruction. So what we put in so far there is the superior mesenteric artery. But of course we haven't really talked about the arterial supply to this region down here. So there's another artery that supplies the descending colon, sigmoid colon and rectum. And that artery is the inferior mesenteric artery. So I'm going to add that in, so don't freak out. Whoops, there we go, that's the marginal artery. There we go. So that's the inferior mesenteric artery. So if we label that up, there's our inferior mesenteric artery. It's got a branch to the descending colon, that's the left colic artery. Branches to the sigmoid colon, that's sigmoid arteries. And a branch which I've made dashed because it's behind the rectum, goes down towards the anorectal junction, and that's the superior rectal arteries. So there's quite a lot of detail there, but the take-home message is you've got blood supply to the appendix, cecum, ascending colon, transverse colon from the superior mesenteric